Professor Marcus, I want to take a few minutes of your time to talk about a critical care presentation that involves the biliary system, hepatitis and cirrhosis. First, let's talk about hepatitis. Hepatitis, of course, involves the liver. The liver is our second largest organ, quite resilient and involved with many aspects of digestion, including coagulation also. Well, with hepatitis, you can have types A, B, C, D, and E, and they are viruses. Viruses are self-limited, so most of the time if the patients themselves become stronger, the virus will dissipate. However, hepatitis A and E are caused by contaminated food, and B, C, and D infected bodily fluids. Hepatitis can be a problem if it's not resolved, because then it can harm the liver permanently. And that's when we get into cirrhosis of the liver. We understand the liver is a fascinating organ. It's rather large, as I said, it's the second largest organ, and if it has permanent scarring, it can have a plethoric amount of problems that will come after that. Let's remember what the liver does. It's involved with digestion and bile secretion. That's stored in the gallbladder. So bilirubin is part of bile. One thing you'll see with patients that have cirrhosis of the liver is jaundice, and this is a result of the bilirubin. What's interesting again about the liver is that in a transplant situation, pieces of the liver can be transplanted, and guess what? The liver actually grows back. The cirrhosis is the scarring and necrosis of the liver. Once this happens, there's really no turning back. At that point, the patients are going to have pretty strong symptoms and problems of health. Obviously, risk factors for cirrhosis, as I mentioned, hepatitis that's not resolved, but also alcohol consumption. We can have medication-induced cirrhosis. And also interesting right-sided failure. With pressure changes and the portal system, this can affect the liver. What do we find with patients with cirrhosis? They're having nutritional problems, they're having weight loss, they're having abdominal pain. They may have bleeding, because don't forget the liver is involved with coagulation and vitamin K. They will have enlarged spleens. They will have, as I mentioned, jaundice and something called ascites. Ascites is a building of fluid from the portal system in the abdomen. And we're going to talk about paracentesis in a minute. What else would patients with cirrhosis have? They have petechiae, or spiral angiomas on their hands, on their body. They have dependent edema. They have asterisks, which is from the ammonia that builds up. You will see this. This is always asked on boards many times. Tremors also. What do we see with the labs? We see problems with unconjugated bilirubin. Serum albumin is actually decreased. Remember, the liver breaks down protein. Then the protein will go from ammonia to urea. But because the liver's not working, the ammonia builds up. Ammonia can cross the blood-brain barrier, and you can have hepatic encephalopathy. So in the case of labs, we will find that the protein is actually decreased and the albumin is decreased. The hematocrit is decreased. Platelets are decreased. The ProTime and international ratio anticoagulation is decreased because the coagulation is involved with the vitamin K. Again, elevated ammonia levels. This is a classic question that's asked with this juxtaposed situation of the protein and the ammonia being high and the protein being low. How do we diagnose these patients? We do ultrasounds of the abdomen. We do CT scans, MRIs. We do liver biopsies. We do EGDs, which is esophageal gastroduodenoscopies, and we give them diuretics and also beta blockers. Let's talk about what happens. We have pressure changes that occur because the liver is not doing what's supposed to do. Because there's major veins there, we have a backup of the pressures, the ascites. The other thing that happens is it goes into the esophagus. So you have esophageal varices. These patients have projectile hemophysis and bleeding. And what we do many times is we actually put a balloon tamponade into the esophagus to prevent this. We have, as I said, we do paracentesis. I would like to show you what that is. You as a nurse will assist with gaining consent for this, and you will make sure that the site that's used for the paracentesis, that pressure is put on it. So the physician, the gastroenterologist, will actually make an opening to drain the fluid and the ascites. They make the decision how much should be drained. You will be there, make sure we don't see blood pressure changes, keeping the patient calm and a supine position. That is your responsibility. After the paracentesis, we check that fluid, it's sent to the lab, and you will check the site for bleeding. Other things with the liver that you need to understand. If the patient is a candidate for a transplant, these patients will be put on immunosuppressive drugs. And then we get into problems with white blood cell depression. Again, you as a nurse need to check that. What kind of diets are these patients on? High calorie, low fat, low protein. Fluid restrictions are maintained. So, what you need to know, critical care presentation for the liver. It is a multifaceted organ. Once the liver is in trouble, there is, as I mentioned, a domino effect of problems, including coagulation, esophageal varices, ascites, bleeding problem. Patients have to be watched closely. Obviously, if it's alcohol-induced, we encouraged them to get into an alcohol cessation program. Basically, that's it in a nutshell. Thank you for your time.